We are getting ready for our next speaker. It's my pleasure to announce our next speaker, Jennifer Lynn Stone. She is an advanced clinical nurse for pediatric pulmonology and sleep medicine. She received her training at Cleveland State University. She is well celebrated and was recently nominated for a Patient Experience Champion Award. Please help me welcome Miss Jennifer Stone. My pleasure to be here today. Forgive me, I'm going to be looking down at my notes a lot, and that's because I can talk about sleep medicine all day, right? So I do it all day long for my job, so I could stand up here and go on and on and on with a lot of stories. So I'm actually going to look at my notes just so I stay on point. So sorry I'm not, making eye contact the whole time. Because I want to keep on track for you guys. So, but it's my pleasure to be here today. I'm really happy to share the basics of sleep medicine. I'm hopeful that this information is useful to your practice in primary care. Truly, when it comes to sleep medicine, everything that you need to know is beyond the scope of my talk. I've been at Rainbow for 10 years now. And the bulk of that has been in the pulmonary division. I work for two pediatric pulmonary and sleep medicine doctors here at Rainbow, Dr. Carol Rosen and Dr. Christy Ross. And the bulk of my talk doesn't come from the textbooks and the articles and the research. It doesn't come from that. It comes from just my observational experience in supporting them and being a physician under them. So they are the ones that have studied the material or even contributed to those texts, and I've just absorbed it over time. So if you have any questions, I'm happy to try and answer, but I might also go back to them and get back to you. So feel free to drop me an email when we're done if anything is right or you're not sure about exactly what I had said. So, slide, your general purpose slide. Formal purpose of my talk is might already know to develop sleep habits in general, but then also I want to give you some key things to keep in mind at every age group of kids that you see in practice, and then some guidance in the more important area of managing your patient sleep problems. Like behavioral interventions are going to be important. And of course, I'll go over medications and when to place referral. Objectives. So everybody sleeps, right? It's a big chunk of our lives. This information can be applied to every single person that walks into your clinic. So you see, after my talk, hopefully you will walk out and use screening tools that are super efficient and quick, and you will have the knowledge base to manage sleep problems in your practice. Of the most common sleep categories over. So this is a super important slide, right? Because we're at a pharmacology conference for ACN. So it states that your pharmacological details of this presentation, are written there, and it was probably one of the hardest slides for me to come up with to really sort of focus on what the pharmacological emphasis of talking about sleep medicine is going to be. And that's because I'm not here about medicine. That's the truth. So feedback from your previous conferences is that you wanted to learn about more sleep medicine. And although I'm not an APRN, I've acted almost as a physician extender for a very long time. I've supported, very good sleep doctors in our area. I'm thrilled for that to qualify me to be competent enough to teach you. So it's great to have this opportunity really to tell you what a lot of the primary care providers in our area are doing wrong. That's throwing drugs at sleep problems. For the continuing education credit, yeah, we'll talk a little bit about drugs and medications. More we'll talk about how they're all off-label and they're misused. And the bigger message that I hope to deliver is that drugs are used for diseases, yes, and disorders. They are never our priority in sleep medicine. More about sleep medicine, you're going to want to know what the sleep medicine specialist advises in their clinics and sleep health. So I appreciate the need for efficiency in your clinics. I say that just as a mom that comes to clinics and wants to talk about a lot of things, and I've got a very small amount of time to get through some stuff. So I can appreciate that. So I want to stay back here and be able to give you a firm understanding of what's normal in sleep and use some quick screeners called box and bears. So hopefully those are the take-home things that you're going to have built into your notes and stuff from here on out. And then, you know, from having those, it should empower you to handle all things sleep will inevitably come up in your practice. So this is a great poster. It is online in all different shapes and sizes, and it can get printed and hung up in all of your clinics. I would love to see it in a pediatrician's office if I'm in. So circle back to sleepeducation.org if you can, and that's really great handouts that they have on there. Here is what is enough sleep? Maybe a question that can at you as providers, you know, what is enough sleep for my kid? The answer to that is it's the amount of sleep that a person or a kid needs to feel well rested. It'll be a giant range. You know, it's going to be different for each child, but it does fall within range, and we can talk about each of those ranges. Keep in mind through all of this that sleep problems in children are quite different than what they are in adults. So they are being delivered to you by a parent, usually telling you what the sleep problem is. And so it's a highly subjective view of what is causing the sleep issue. And it often correlates with how much of a disruption it is to the parent or to the household. You know, the big problems are being a big disruption to the sibling down the hall or the mom's sleep schedule or the dad who has to get up for work early. That can sort of escalate the angst in the family of needing to get this sleep problem fixed. The needs, I guess I would say, so needs of your pediatric patients are changing as they go and develop, right? It's best and easiest to frame your understanding of what is healthy sleep age groups, and then further emphasize what healthy habits are and what they should be practiced in each age group. So on 6 slides, I'm going to talk about healthy sleep habits for the age group. On each slide, you'll see I've defined what the age group is. I've given you the full range of how much sleep could be reported in that age group. And I sort of mentioned at the averages, so more what you're going to see more commonly. But it's good to know that it could go outside of what that average range is. And then just have a couple things typed on there for you to remember, or maybe if you ever slides or something, we want to read what you learned from Jen Stone, the sleep nurse. Hopefully these little one-liners will just help give you a refreshment of what you had, or I had talked about today. And so I'm just reading those two, I'm actually going to spend all of my time talking on these slides about other things that aren't listed here. So jot down anything that maybe catches your thoughts or that you wanted to hear again or hear me elaborate on. I can grab that stuff at the end if I can stay on to keep looking at my notes and staying on track of everything. So just jot something down if it doesn't make sense to you. Newborns. Safe sleep is daylight in newborns. All other advice, I guess, from 0 to 2 months old is like total free for all. So circadian rhythms and their melatonin production is completely mature at this point. So sleep is about half active sleep and half quiet sleep. Those are what they use. And by active, it's like the wincing and the grimacing and the moving around and the twitching that you do when a little newborn is sleeping. It doesn't mean that they're awake, and it doesn't mean that they're getting bad sleep when making all of those movements. And then quiet sleep is also about 50 said, and it's not like quiet sleep is any more restorative or better than the active sleep that you're seeing. So important thing to remember at this age is that breathing patterns are highly irregular. I'm sure you counseled patients before on just the ups and downs and the fast breathing and then the long pauses and then going again. So that's a real thing, and it can also be brought to you as a problem. They're breathing funny, and I'm concerned about their breathing. So just keep that in mind. Irregular breathing is totally normal. Well, the sleep in newborns, it's just largely on hunger. So if the sleep problem is coming to you and with a newborn in your office, most likely the problem is not so much, the sleep problem in the kid. It's the mom, because they're based on hunger. So mom get out in the middle of the night to eat things like that. That's your first 2 months. Sleep and regulation occur in the first 6 months of life. So common sleep issues that are going to pop up in your infant population are troubles with self-soothing, putting themselves to sleep, falling asleep independently, consolidating their sleep, getting longer chunks at night is always a goal. Problems with sleep onset associations, which like needing to be rocked to sleep or needing a bottle in order to fall asleep. We don't want those, are bad, And then arousals, waking up during. Those are problems that are going to come to you, or things that people are going to describe or sleep problems with their infant in your office. At age, it's not too early to have a bedtime routine and to start sticking to it. So counseling your patients on establishing a bedtime routine and doing it right will really make a big impact on their ability to consolidate and self-soothe and regulate their sleep patterns. Getting put to sleep, drowsy, but awake, on age. So not totally asleep, not falling asleep in your arms on the couch and then being transferred to the bed. Put it in bed, drowsy, still awake, and essentially teaching them how to put themselves to sleep. In Academy of Pediatrics, right, they are good with pacifiers. So your night feeding should be going away in this time frame. They really aren't needed. And so when fed at night or getting fed last before bed, it ends up being a sleep onset association. So we want to sort of avoid that being a thing. Several times throughout the night at this age is totally normal. And I actually say a lot in clinic that it is completely normal for kids to wake up several times a night or 5 times a night. The kids that can't self-soothe and put themselves to sleep at the night, they're looking for whatever they get at bedtime in the middle of the night to be able to put themselves back to sleep. So let's remember that there's middle of the night problems in kids, you want a bedtime routine. And their involvement in that bedtime routine, they're going to night. So focus time routine, you offer some guidance and some help in any kind of night. Sleep just also occurs around milestones. So child development, 0 to 6 months old, 2 to 12 months old, there are some big changes that are happening. And there's a big change from, they're in rollover this week to they're cutting their first tooth at 11, 12 months. You notice the sleep disruption. It's happens. So for toddlers, your problems are common. Actually, toddler sleep problems are a big deal. But they're mostly fixable with routines, again. So it's the same thing I just talked about. Your problems coming to you at the toddler age are the ones that are having night wakings and needing mom or needing somebody to go rub their back till they go back to sleep, or go in and give them their pacifier, give them their blankie, and that's what they need to do to go back to sleep. Again, focusing back on what the bedtime routine is and putting kids drowsy or putting them to bed drowsy but still awake, and have them initiate sleep independently without your presence, a big key in helping with any kind of nighttime issues. Some of the outcomes at this age are stemming from wanting to give a nap. 3 years, they're wanting to give up a nap and cause some issues. Lots of times it's, the wanting to give up a nap in the afternoon, and then the following at 5 o'clock in the car ride home, and let's sing along, we don't want to fall asleep, let's stay awake, and then pushing bedtime later because they had that little late afternoon nap, and then a whole schedule issue occurs. So those are things that can come up at this stage. So when they're transitioning from a crib to a toddler bed, can cause some new problems that might be brought to you in clinic. And good to just keep in mind that in this age range, a lot of problems that are going to pop up are transient and totally self-limited. So it's just a phase, and it'll matter. Get to your team when telling them that as well. The ripple effect of sleep problems in toddlers, it can make a big, it can be a big stressor for a whole household. So it has a giant impact on the parents' sleep, and then their ability to get up the next day, and their ability to function at work. So, full consideration when you're talking about these sleep problems at that age. Careful consideration should be given to the causes and the contributing factors that are going into it. So many transitory disorders, meaning it's a problem that could be short-lived. It would probably just go away eventually in a very short amount of time. Many of those sleep disruptions, they can become disorders if parents wrong advice on how to respond to them. To reinforce any behaviors that might down the line be another sleep problem or a sleep disorder that needs further evaluation. All of that is to transition a toddler bed and curtain calls, you call them. You say you leave, you close the door, and you're getting called for back, and you need like one more hug, or I need it, or I can't see light, or I need water, or I could go on, right? I said that. I can talk about this all day. That is, the more we respond to those curtain calls and talking and stimulation, if we're touching and engaging with them with all of those curtain calls, if that's what we're doing, that will most likely turn into a sleep onset delay and cause shortness in the amount of sleep that they're getting overnight. They're in the bed at 8 still, they're probably falling asleep until well after 9 because we're having all those curtain calls in there. So addressing that sort of stuff is important. Preschool age children, preschool naps decrease from 1 to none at this time. So your easy way of thinking, I guess, is about half a 3-year-old still nap, about a 4-year-old still nap, and 15% of 5-year-olds nap. No reason to one household being one way and the other kid in your household being another way. It's a experience. I had a kindergartner that still naps. I had a 3-year-old that drove me crazy because I needed that time, but he was with it. So, at age, there's certain if you're sending them to daycare or you're having home, either way, routine, right? There's daycare, there's routines at schools. They've got snack and meals and playtime and storybook and carpet time and station all mapped out for them, and they have that same routine every single day. So that extra works for schools. That's why I do it. For home, and then with your bedtime routine, you need a routine for your bedtime routine. We put on, we brush our teeth, we read a story, we say good night, and you go to bed. So routine is a big deal. I'm going to show you a few slides in. I'm going to refer to it now. So there's a big behavioral component that can pop up at bedtime in the group, and it can get exaggerated, really, in this age group when we call it the forbidden zone, when we try to put kids to bed when they have this sort of natural circadian push to be more alert at the end of the day. So we call it the forbidden zone. Try to put them to bed when they're like totally wired, and you know, the problem that would come to you in clinic or as a provider, they would say to you, you know, they're awake at bedtime. Like they're wide awake, I can't get them to go to sleep. So their natural circadian push at the end of the night to stay awake. You just want to stay away from it. You don't want to do time asleep during that. Better off waiting until it gets back down and then trying your sleep routine. So more if we have questions about it, but it's just something to keep in mind. School age children this age are schedule irregularity. So most of them have it down pat during the week, right? Because they're all now anchored by wake up time for school. So every single day they've got to get up at the same time so they can get to school on time. So anchoring a wake up time is a great way to keep a routine. The schedule at this age is those Saturday and Sundays where they all get to sleep in a little bit. And we were like, oh, they're still sleeping. It gives you a little bit more time in the morning because you're so used to getting up with them and getting going in the early hours. So maintaining the same schedule, weekdays to weekends. I know it sounds crazy. If you have to get up with your school in during the week, you should probably be getting up by 7:30 or so on the weekends with them. Letting them sleep in more than 2 hours, that does is it just puts that circadian rhythm a little bit later, and then they're not going to be ready for sleep at the same time they are during. Your Saturday later, your day shift a little bit later, and Monday morning something. So regularity can cause a big problem. Meeting parents in the bedroom at bedtime. Again, it's back to the Sleep Onset Association and what you're sort of reinforcing. This alone bed and trying to put yourself to sleep, not needing somebody there in order to initiate sleep. And there's wind, which again, there's a diagram coming up. I'll show it up. I'll talk about it more. Wind this age as well. So this little burst of energy right before the bedtime routine, you just let it happen or get to know it or be aware of it, and or try to just say, well, it is 8 o'clock. This is when we go to bed. Because if they're in that, you're going to meet a lot of bedtime. Electronics is on there. Sometimes when kids get that second wind at the end of the night, it's very easy to hand them a pad, and that's when they get their iPad, and they lay in bed, and we have a timer, and it turns off automatically. Don't start with the at time to try and give them something to do during the bedtime routine. Big no. Adolescents. But it's really important on this slide that you see where the average duration time that adolescents are sleeping, it does to what the range of sleep is for this age group. See that? Adding 7 to 7.5 hours of sleep at night. But in sleep health, they should be in 9 and order range. An important thing. So adolescents, or I like to call them screenagers. Have you guys heard that one? Screenagers. They're on their screen. And lifestyle factors are going to play your biggest role in any of the sleep problems that pop up at this age. From social things going on, being on their screen, checking in with social media, they not wanting to miss anything that happened in the last hour. School demands, lots of homework, lots of sport demands, extracurricular activities. You throw a couple of those in there, and there is just not enough hours in the day, right? With all of the early school start times in our area, in Ohio, in our state, in our country, it's a big issue. They are just a chronically short on sleep population. Some of their own. Lots of I'm going to refer to this slide I'm going to show you. Have a natural circadian that occurs in adults where they fall asleep much before 11 p.m. And so it's, when teenagers are saying they're staying up later and they're on their phones and they're on their tablets and stuff like that, that's another piece of it. But it's that they really can't fall asleep much before 11 p.m. It's a natural thing. It's shifting from adolescence sort of towards adulthood where, we probably don't fall asleep much before 1:30 average adult. That school start time and the time means that a lot of our teenagers are setting them out the door and things. Short on sleep, 7 hours, not getting enough. Short on sleep every day is they accrue sleep debt. That's what we call it. You're accruing sleep debt. So if you're supposed to be getting 9 hours and you're only getting about 7, just bank 2 hours of sleep debt. That just compounds throughout the week because that all keeps going off for school, right? And then that happens. What do? They till noon. Some of these teenagers will sleep in so long. Figure out what happens when we shift their schedules on the weekend. It's called social. Talk about it more. But then just pushing their ability to fall asleep later. And then Monday morning again is no fun in your house. A teenager that goes to bed at 11 and has to get up for 6 at school, for example, I've heard even worse. I've heard 5 o'clock hours sometimes for kids to be getting up for school. They've essentially been awake for 17 hours. A person's cognitive function, there's that show this a person's cognitive function, their ability to make decisions after 17 hours of being awake is to a blood alcohol content of 0.06. So in our state, I think our limit for adults is 0.08. It's counterintuitive, actually, a legal limit for minors. So, if a teenager was drinking and driving, they would go over a 0.03. That's a deal. So our cognitive function after 17 hours of being awake is equivalent to 0.06. All of our teenagers that are chronically short on sleep are drivers, or drunk drivers. Take-home message for parents, especially getting their temps at 15 and getting ready to drive at 16. They get up on Friday, they're out all day. They home, they've got after-school activities, they go to a game or whatever, and they're driving themselves, and they're going to bring themselves home at 11 o'clock. When I think of those facts. So about what's important to remember in the teenage population, make sleep a priority in your house. So early school start times, I can't fix that natural circadian towards, later bedtime. What brings out of the bedroom? I can swim an hour before bed. I make exceptions to that rule, and I can be consistent on the weekends, and then I sleep. And understand the more you do those sort of things, the better chances they are of functioning better during the day compared to doing them. Dr. Rosen, she said I have it in here. And I've seen similar ones in the text. And it's really hard for me to understand, actually. And it's even harder for me to explain to you, but I know it's important. There's some big take-home messages on this one. Times, but if it brings any questions up, we'll talk them later, I promise. So this is like the two processes. This is what makes us sleep. This is like the answer to why do we fall asleep. So not marked on your slides, the bars that are coming down from the top, kind of just really coming down in a diamond on the top. Those bars represent your sleep load, okay? So sleep load is, it's increasing pressure that just builds along the wake. The bar is getting longer and longer throughout the day. The pressure to go to sleep that just accrues the longer we're awake. Okay? The bottom kind of go down with that black line. Those are natural circadian rhythm. And rhythm a little bit longer, or a bit later in the presentation. But for circadian, and I like to look at those bars as sort of this awake flow that kind of down throughout the day. Brain's natural strengths in telling us that we're sleeping or we should be awake. The that will through the middle, that is just a representative of our wakefulness during the day when you take into account the drive to sleep that accrues the longer you're awake, and the circadian rhythm that kind of goes up and down throughout the day for a variety of reasons. We even see that wakefulness line, it sort of dips after noon. Remember, like the energy commercials, they talk about that 2:30 feeling. So it's a real thing, right? Because there's like we've got this sort of circadian shift in the afternoons after lunch that sort of pushes us being more in the sleep range. And then in the early evenings. So what fall asleep, your load peak or be its strongest when the wakefulness of your clock hit the low point. So where this is kind of into in sync or being harmonized. So that allow us to fall asleep, allow sleep to. I got one justice. Put it in there. A good sleep hygiene. So what causes us to sleep? What are the you can do to be a good sleeper? Well, you can have good sleep hygiene. Hygiene with our patients, brushing, taking showers. You're talking about caring for their skin, caring for me. Sleep is something to have good sleep hygiene for. So here's one of your good sleep hygiene things. This is on there, 30 to 60 minutes of exercise a day has a great effect on your sleep. One of those things is that really having good, better exercise every day, and we should also be counseling our patients on every day. So that's a big one. Avoid blurs, those are the screens and things like that I was telling you about. Poor sleep hygiene you think about what day is poor sleep, things that we do during the day that are pretty much going to guarantee that we're going to have bad sleep later. That's sort of what this list is. Nikki thought of it's just something I threw on there because it's like an adult thing. There's a lot of dating now, right, in schools, so it's important to keep that in mind. It's something that could be impacting patients. When you think of consequences of poor sleep, so when you have a bad night's rest, when you think of that causes irritability, decrease in its impact on our overall health, our patients, our behavior, and getting discussions in clinic or actions as a primary care provider with your patients about what's going on, and they're talking about these daytime things. It should show what's going on with your sleep. What all of the sleep disorders that could present to you as a provider? There's a lot of them, right? They all fall into what we call these 6 categories of sleep medicine. So fit nicely into them, and you have a general idea of what these 6 categories are. It might help guide you in teasing out what problems might be causing the sleep in your patient. These, same thing as I did the healthy sleep habit slides. I'm going to go through them and going to have what it is and a couple of the more common diagnoses that you would see within those domains. And then I'll talk a little bit about each of them. I'm not going to go into heavy detail about it a lot, but just kind of knowing the names and knowing that those are really diagnoses is helpful. So sleep-related breathing disorders. So child sleep apnea occurs in about 2% of children. Most commonly diagnosed or found in preschoolers, and their tonsils and their adenoids are large compared to their throat. So it's an obstruction, a narrowing, or collapsing of their airway when they're sleeping at night, causing snoring noise. The different indications within the infant sleep apnea usually has more of a developmental cause, so material delays or kids being in clinic, infant sleep apnea be there. Pediatric sleep apnea, most often the anatomic cause, so tonsils. Then has a neurological or a cardiac cause. And know that there are other things that you're going to probably see a lot of that will definitely drive up the risk for sleep apnea in kids. Obesity, Down syndrome, things like that. Sleep-related, so syndrome, it's a thing. It's just an irresistible urge to move. So when you stop moving, so if it happens most commonly when they lie down at night ready for bed. Movement. So that when they're moving around during the day, they don't notice it as much. But then laying down at night and they start feeling it, they have urge to move around their legs, and they kick around and move and twitch a lot in their bed. The periodic disorder, that's another one that you might sometimes see on sleep study reports. You might see restless period or the number of periodic limb movements throughout the night. It's like a presence of this like stereotyped limb jerk movements that happen in sleep. And actually just happen in like your toes and your ankles. It could be like a toe keeps moving down while they're sleeping. But the thing to know about those is they may cause arousal. Okay, so if in your clinic is that they're waking up at night you want to ask about leg pains or twitching or moving around or kicking a lot in their sleep. Head rocking, head rolling, those are all benign self-behaviors that happen at sleep. They occur, during the transition to sleep. They can happen at nap time. They can happen at bedtime. They last minutes to hours. They're not known to cause really any significant disruption to sleep, but they're all concerning to parents. So you'll probably hear about it. Shocking. Or they usually fear injury. The parents will usually fear that they're going to get it because they're moving around and they're going to sleep. But it's actually really rare. Paroxysm, that's your standard. Circadian rhythm, so broken down into two categories: chronic, usually electrical cause. Ones usually have more of a social or environmental cause. So circadian rhythms a little bit more. So your circadian rhythm, it is a cycle that happens in all living things according to the 24-hour rotation of the Earth. Actual word circadian, it means something like roughly daily. So it's roughly daily patterns of being awake and asleep, thinking a bit longer than 24 hours. Rhythms are impacted by external factors. That's an important thing to you can imagine that various disorders arise when you take into consideration all of the external factors that could be making an impact on a child's sleep. Up here is light. Our brains know it's designed to be asleep. They reduce our melatonin when it comes into dark. So I mentioned at the bottom, maybe it's not this one, but that screen and technology is starting to have like an increased demand at night. And so if there are some circadian rhythm problems going on, it might be that they're getting exposed to light at night on the screen. Uses sunlight to determine how much of that sleep-promoting hormone melatonin it should produce. There, real quick, I'll just say delayed sleep phase disorder, that is when you're shifted more than 2 hours than what's really acceptable. Shift disorder, that's just a conflict with your schedule and your internal circadian rhythm. Your sleep phase disorder, that's when sleep times are just total alignment. There's no clear pattern, doesn't add up to what's the normal amount of sleep. It can cause by brain damage. 4, that's your bedtime gets later and later and later every single night. You just sort of end up like going around the clock over time. Set up already, that's the have a schedule during the week and then sleeping in on the weekends. Kind of like their internal clock is flying over to California and then home for Monday morning. They say take 1 day per time zone to sort of reset your clock to the local time. It's important to remember that, if you went for a couple days and you got home, you can imagine a couple days of trying to do it. With drowsy, dry, when you have any sort of circadian problems, delays in going to sleep or short on sleep, I'll talk about that when I talk about hypersomnia. So yeah, divided up into 2 categories, non-REM and REM. So they're non-parasomnias as they can still move around, but they're not awake. Your REM parasomnias as they don't move, but they can wake up. Still have skeletal muscle tone, has to do with sleep staging, and REM is when you have like muscle tone basically. I mean, you have diaphragm and your ears still work, and your erectile muscles. they have much muscle tone during REM. That's when we're dreaming. It's by design, right? If we were dreaming and we had muscle, we'd be or running or doing everything that we're dreaming about, we'd be doing it. So every 1.5 to 2 hours during normal sleep. So parasomnias are usually episodic and undesirable behaviors of sleep. So they're things that go bump in the night for families. They are just unwanted experiences. They can happen falling asleep, when you're sleeping in the night, or when you're waking up. There are partial arousal types that are the ones that occur during the non-REM sleep, which their body can move around, still has muscle function. So those are your like half asleep problems. Those are your sleepwalkers. They use early in the night because we have less REM in the early part of the night. Kids with these problems can be agitated with their eyes open and screaming. They're totally have to wake up. And when they wake up, they're confused and they don't remember what's going on. They really don't remember the episode the next day. Aggravated by insufficient sleep. So the old adage, you know, oh, they were like crazy today and went to bed late, they're going to sleep good. It's actually like total opposite with kids that have these kinds of problems. When you're short on sleep, you tend to blend your sleep stages a little bit quicker, and that just prompts these sorts of things to pop to sleep. Night, the second half of the night, because that's when the bulk of our REM is occurring, in the second half of the night. There's our dreams. They awaken the child. Usually can delay the child going back to sleep. There's usually fear, anxiety, negative emotions. Kids will be afraid to go back to sleep, and they'll seek a parent for comfort. There's a little confusion or disorientation. They know exactly what they just dreamt about, and they thought it was really scary. So they can recall what happened. That's a whole other talk of its own. We can talk a little bit later, but it's in this category. So narcolepsy, or with epilepsy, hypersomnia can be organic or idiopathic. There's a couple other ones that you should just be familiar with the names and maybe look them up. You have a brief description, but knowing about them is important. Narcolepsy is a chronic, lifelong CNS disorder. We call the Rosen sign. And then if the kids see they're there for a well child test, they're not otherwise sick, or if you walk in the room and they're asleep on the exam table, especially like school age, we say that's narcolepsy until proven otherwise. Because it's not during the day if you're getting good sleep at night. I have a full explanation of narcolepsy that I give to families, how to see little broken receptors in the brain that tell us when to be awake and when to be asleep. For a reason, in a patient with narcolepsy, they have less of them or theirs are broken. So their brain has a hard time telling them that they should be awake and they should be. And kids with narcolepsy, those receptors are broken during the day, you know, so that's the classic sleepiness during the day, falling asleep in class, falling asleep at a well child check on the exam table, things like that. Are also at night. So epilepsy have really fragmented sleep and can be up and down a lot at night, move around a lot at night, feel like they're late. And so we think, oh, it's just because they get bad sleep, that's why they're sleepy during the day. But the characteristics of narcolepsy. Idiopathic disorder, much like narcolepsy, it just doesn't have the cataplexy piece to it. Cataplexy is a sudden loss of muscle tone, happens with strong emotion. So see kids that, you know, their legs get weak when they're scared, or their eyelids or their mouths will like droop with really emotion, and you'll just kind of see them lose their air or laughing. They kind of laugh because they always feel that their mouth will drop open. So that's cataplexy thing, and that's unique to narcolepsy. With idiopathic hypersomnia, there's a couple of things really unique to it, usually sleep inertia. So a parent that brings their teenager in, I just cannot get them out of bed in the morning. It's like sleep drunkenness. They cannot wake up. Sleep, and if getting plenty of sleep the night before, it might be a hypersomnia diagnosis. Hypersomnia, epilepsy, those can follow viral illnesses and head injury. So have a family talking about how sleepy their kid is, kind of kick back a little bit and saying, you know, do you have any big illnesses last year? Did you have the H1N1 flu? We had a giant big narcolepsy after that flu. Questions. Oh, they had it last summer, and then all of a sudden they're just like super sleepy. That can be a rare sleep disorder that causes episodic, recurrent, prolonged bouts of hypersomnia. So that's a weird one, but just that it's a sleepy problem. So 6 domains of sleep medicine. The last one here is insomnia. I'm going to go quick here just to realize I've gone too long. So common sleep problem and trouble falling asleep, trouble staying asleep, trouble feeling refreshed after sleep. Those are your big. We can talk about it more if we need to, or I can give more information if you guys need sleep. And all of these things are not covered. There are so many sleep problems out there that might present to the care. So when children are complicated by one of these and there's some sleep problems, just knowing that it's time to refer is key. Fox and bears is the next thing I'm getting into. So using these two tools can really help you identify sleep problems. So we can, you know, build this right into what our assessment is. We call it our sleep vital sign. There are questions that every primary care doctor should be giving, asking all of their patients. Do they maintain a regular schedule? Is that right? Is that regular 7 days a week? Are they sleepy or overtired during the day? Do they have any problems at bedtime? Do they have problems falling asleep or problems waking up? Do they wake during the night? Do they have any unusual behaviors during the night? Do they snore? Or do more? That's one reminder. Familiar with the AAP clinical practice guidelines for look to OSA in kids, but it's based on one of them. So it's used to elicit all of those different groups of sleep problems, bedtime issues, excessive daytime sleepiness, night awakenings, and duration of sleep, and snoring. So if you're asking about those things, you are basically gathering your top 6 domains of sleep medicine and maybe eliciting a problem in one of those if you're asking about all of those things. So primary care interventions that you can do for sleep problems. So what can you do? You can know what's normal. Just gone over way too long. You can encourage healthy sleep habits. You can educate on the behavioral and lifestyle changes to improve and achieve more healthy sleep habits. And knowing the domains for narrowing what the problem could be is super helpful. Likely, what you're going to do, refer to a specialist or extra procedures, or there's medications, provide medication. That's because in almost all cases, medicine for a sleep problem is never the first nor the only treatment choice. So per score, here we're at, and I'm far behind, so I apologize because I'm going to go quick through this. They actually have drugs on them for your pharmacology. So these also are divided into 2 sections. There's most common pharmacotherapies written on each of them. There's tips to remember in sleep practice. I want you to note that common in that sense is not, it's common pharmacotherapies, but it doesn't mean that, it means that they're commonly used or they're commonly accepted or they're commonly misused or they're commonly tried and failed. So just know that common doesn't mean that it's what's the right thing to do. So in sleep-related breathing disorders, if there's snoring and tonsillar hypertrophy, you should be doing more. So address nasal obstruction right off the bat with a nose spray. Lots of times send them to an ENT. They'll start with that. See if they shrink some of the tissues, open up the airway a little bit more, and allow them to breathe better at night. A clinical practice guideline for it is that all children should be screened for OSA or symptoms. Movement disorders. I think the thing to remember here is that or moving around or kicking around a lot at night can trigger wakings. So if someone presents to you as my kid wakes up a whole bunch during the night, you're asking about leg movements. Part of RLS, but it's more frequently described as an urge. So you would do a neuro exam to rule out any problems, but you would want to consider their iron stores. My way of explaining it to families, again, it might not make total sense, but I just say that iron helps deliver the blood around our body. And if we don't have a lot in our bloodstream, we have nothing from our ferritin, I call it our ferritin pantry, nothing in our ferritin pantry to pull from, we kick around and move our legs around at night to get the blood pumping down there. And it's urge to move. And so ferritin level, their iron stores, if it's low or even on the lower end of normal, range of the ferritin is a huge range in kids. It's 300, I think, in some of the ages. So that means that they have a giant pantry. So iron supplement for a few months, like at a higher dosing, 2 to 3 milligrams per kilogram, just sort of build up their ferritin level, build up their iron stores, sometimes makes a big difference in just leg movements and the kicking at night. So that's right. It might help decrease the amount of night wakings if that's if they present with waking up a lot and leg pains or kicking around a lot. For rhythmic movement disorders, that's something, the body rocking and everything. When I was doing that, I looked at the doctors. I was like, do we even prescribe for parasomnia? That was and generally, and we don't. So, I mean, parasomnias are normal behaviors that happen for a lot of reasons. Meds are only used in the most severe cases, and usually only after seizures have been let out. So in which case, if there's parasomnias and you're thinking that you need to give this kid a medicine because the family is totally exhausted and in crisis talking to you about it, that's when you just refer to a specialist from it. I have some antidepressants written on there. So benzos are used in the most extreme cases, and all of our data on this is based on adults. So that's circadian rhythm, melatonin. Ooh, this is where melatonin comes in. So the one thing I want you guys to remember walking out of here today, if I could tell how many kids come to sleep clinic, melatonin. If you think they're to a sleep specialist already on, and why? And we throw a lot of melatonin at kids. And so many cognitive behavioral approaches to fixing circadian problems that are well studied, accepted. And so throwing melatonin, which has a lot of variability in just the formulation of it and everything that's out there, it's great. Not a great fit. Type 2, their hypersomnia stuff like narcolepsy and cataplexy, we use a lot of the ADHD meds. This is a really interesting slide. I wish I would have talked faster because I love talking about how kids with anxiety and depression and ADHD, they're on stimulants and antidepressants. And narcolepsy and cataplexy, we treat with stimulants and antidepressants. And a lot of kids that come to us finally after trying ADHD and anxiety meds and depression meds, we kind of step back and we realize that they truly have narcolepsy with cataplexy. And that's what they're often misdiagnosed. And so again, this is another melatonin thing. The only time we really use melatonin in insomnias, it's for like helping sleep to occur. It's for that are like really short on sleep, melatonin will help, but it's got a very weak hypnotic property. It doesn't kids fall asleep their clock if they need to. Don't give Benadryl. Don't give Benadryl for sleep either. The full effects of it, it's just not great. So what can you order? So all of these things, you can do them or we can do them. That's the good news, and that's the message I want you to take home today. Primary doctors can order a sleep study just like you order a lab or you order a x-ray, right? You would then order to us. We would review your clinical notes. We would say yay or nay. We would plan out the study. We write a lovely report and send it back to you 2 weeks after the sleep study, and it pretty much walks you through how to counsel your patient and what they should do next. So you guys do that. If it's an easy peasy rule out sleep apnea, order a sleep study. They don't have to come to sleep clinic for that. And if you want to know about it, just shoot me a message afterwards. I'm happy to give you the tips. And then those are the other things that you can do with sleep problems. So different, depending on what institution you're at, different specialists are there for referrals. We need to have a behavioral sleep specialist here at Rainbow. She does a lot of cognitive behavioral therapy for insomnia, and she's a great resource. Dr. Carolyn Ivers Landis. She is in developmental behavioral pediatrics. IRS-ANDIS. Resources are there. So the only thing that I wanted to pull up was a video of what a sleep study looks like if you guys are interested. I got like a 30-second clip of what a setup looks like, but it's short on. And I can people too if they want to see. I think that's a big thing is like you don't know what a sleep study involves or what it's going to do, and I think parents have a lot of reservations about putting a whole bunch of sensors on the kids, and messages there is total invasive, super 12-hour overnight, and very maybe. I have my card. You guys, if there are any questions, please email me. I love this. Like I said, I could talk about this all day long, and I really enjoy educating on it. So please shoot an email. I'm happy to share links to videos and stuff. They're actually of my kids, so I'm passionate about teaching about what happens in a sleep lab because I've been there as a mom, so I know about it. Yeah, love to give that advice. That's like. No to the. That's fine. No, don't be sorry. It's okay.
So this is where we're going to split into our breakout sessions. There are two different locations. There's one presentation on opioids, and there's another presentation on dermatologic issues. If you're interested in the opioid presentation, you're going to head straight out up the stairs and across the bridge. If you're interested in the dermatologic talk, it's going to be around the corner, like you're heading towards the bathrooms. And once you get towards the tables, you're going to see a hallway to your right, and there's a sign posted on the door. Belongings with us as there's another group in here during this breakout sessions as well as our lunchtime, and lunch follow these breakout sessions. If you have any questions, you can see Brandy or I in the hallway. Thank you.